This presentation is going to be over the Bennett fracture. This fracture is named after the surgeon Edward Halloran Bennett from Dublin, Ireland. This fracture is the most common fracture involving the thumb, and it occurs at the first metacarpal. It is an intra-articular two-part fracture of the base of the first metacarpal bone. It separates the palmar-ulnar aspect of the first metacarpal base from the remaining first metacarpal. If the fracture is displaced, the fracture becomes unstable. The mechanism of injury is an axial load that occurs on a partially flexed metacarpal. This occurs with activities like boxing, fistfights, and contact sports such as football and rugby. The anatomy is a saddle-shaped articulation with ligaments including the anterior and posterior oblique ligaments, the anterior and posterior intermetacarpal ligaments, and the dorsal radial ligament. The fracture will be distinct. Signs and symptoms include severe pain and weakness of the thumb, swelling of the base of the thumb and back of the hand, numbness or cold sensation in the thumb, misalignment of the thumb, trouble moving the thumb, or bruising of the area around the injury. Active range of motion and passive range of motion should not be performed if the fracture is suspected. If the fracture is displaced, there may be a visible deformity. Palpation will show pain, swelling, and ecchymosis over the carpal-metacarpal joint of the thumb, and the area over the fracture will be warm. This area will also be point tender. Manual muscle testing will show decreased pinch grasp and decreased grip strength. Specialized tests include the long bone compression test, but this should not be performed if the fracture is evident. Stress tests and joint play are not applicable. Diagnostic testing is where you may use X-rays to diagnose the condition, and a CT scan should be used to evaluate the extent of the injury. Stable, non-displaced fractures should be placed in a thumb spica cast for 3 to 4 weeks. Unstable fracture patterns should be treated with an open reduction with internal fixation of either screws or pins. Rehabilitation relies on the stability of the fracture and whether it was treated operatively or non-operatively. Range of motion exercises can begin 5 to 10 days after screw fixation or 4 weeks after pinning. Modalities include cryotherapy, joint mobilization, strength and flexibility exercises, and dexterity re-education.